begin if everybody's ready. Okay. Good afternoon, ladies and gentlemen. Welcome to another session on healthcare organized by the Indian Chamber of Commerce. As you probably know, the ICC is one of the oldest national chamber of commerce of the country, and it has been working for the development of Indian trade and commerce since its inception in 1925. Although we cater to various industry sectors, healthcare has been an important focus for us. Since the lockdown in March, we have been continuing our work on the virtual mode. And today's session specifically is focused on the diabetic foot. And we have a very erudite and knowledgeable panel here with us this afternoon. It is my pleasure to welcome Dr. Kushal Nag, consultant and foot ankle surgeon, Apollo Gleneagles Hospital, Kolkata. He's also the founder director of Cura Foot, and he has kindly agreed to be the moderator for today's session. Welcome, Dr. Nag.
Thank you so much.
We have Dr. Rahul Seth, interventional radiologist, visiting consultant at various hospitals in Mumbai, including Kandy, Lilavati, Jaslok, and many others. Welcome, Dr. Seth. Look forward to your thoughts. We have Dr. V.S. Bedi, Chairman, Institute of Vascular and Endovascular Sciences, Ganga Hospital, New Delhi. Welcome, Dr. Bedi.
Thank you.
We also have Dr. Edward Chok, Senior Consultant, General and Vascular Surgery, Singapore General Hospital. Welcome, Dr. Edward Chok.
Hello.
We are privileged to have with us this afternoon Mr. Prashant Sharma, Chairman, ICC Healthcare Committee and MD, Charnock Hospital. May I request Mr. Sharma to start with the welcome remarks on behalf of the Indian Chamber of Commerce. Over to you, Mr. Sharma.
Very kind of you to say those things. Now, a very warm welcome to all the attendees, a very, very warm welcome to all the dignitaries. We have very senior panelists with us, Dr. Bedi, Dr. Seth, Dr. Edward, and our very own Dr. Kushal Nag. It gives me immense pleasure to welcome you to this webinar, which basically covers the diabetic foot. Diabetes is a leading cause of non-traumatic lower extremity, amputations, and approximately 14 to 24% of patients with diabetes who develop a foot ulcer require amputations. Diabetic foot is one of the most common complications for admissions, imposing tremendous medical and financial burden on our healthcare system. The lifetime risk of a person with diabetes having a foot ulcer could be as high as 25% and is the commonest reason for hospitalization of diabetic patients, about 30%, and absorbs about 20% of the total healthcare cost, more than all other diabetic complications combined. In keeping with the rising burden, India will need to plan for a foot protection service at the primary and the community level to implement the proven cost-effective preventive interventions, which we are learning from other countries as well. The lesser referrals to the hospitals hopefully will, in the future, be treated by a multidisciplinary foot care service at the hospital level using a more robust protocolized care pathway built on Indian audited data and cost impact analysis research. Professionals for this interdisciplinary foot care service will include diabetes physicians, nurses, podiatrists, microbiologists, interventional radiologists, vascular surgeons, wound care nurses, plastic surgeons, and disability specialists. According to World Diabetes Foundation, in India, 32 million people have diabetes. Rough estimates indicate 40,000 lower limb amputations per year, most of them due to diabetes. Diabetes-related amputations are to a large extent preventable when simple measures are applied. Evidence shows that amputations rates can be reduced by 49 to 85% if strategies for prevailing and treating diabetic foot are implemented. Now, in this scenario, we have a very erudite panel with us. Sujay has already mentioned the credentials of all the speakers. On a personal note, when I was going through these points, I had no idea that diabetes could be such a massive burden, both economically and health-wise. We have an extremely varied panel put together by the ICC team, which I must congratulate. And I look forward to this deliberations, and I'm hoping to learn a lot from next 1 hour. Thank you everybody for coming here. It's a great pleasure to have you on board. And Dr. Kushal, now over to you, please.
Thank you, Prashant, for this wonderful introduction. And I think Prashant is a very valid point, right? I mean, the cost of care, and I see so many of our patients reduced to penury, right? I mean, they already spent so much of money running after hospitals. And if we could save not only people from losing their limbs, but also help save them from financial ruin, I think that would be a great thing for a developing country like ours, right? And in that vein, let me start my presentation, and I already have the order of presentation with me, and I'll start, and then my esteemed other panelists will follow me, and I will introduce them as we go along. So I'll just, with your permission, I'll share my screen and start my presentation. Irene, could you enable screen sharing for me? Shujai, could you enable screen sharing?
Yeah, it's been done.
Yeah, okay, great. I'll just go to my, okay. So I've been working in the foot and ankle space for the past 6-7 years. I've realized that the huge amount of people who need proper prevention and care in the very initial stages to further prevent complications like amputations and osteomyelitis and other severe complications of diabetic foot. So how can we make this process simple? Because in a country like ours, we don't have enough specialists, foot specialists or interventional radiologists, or there are very few in numbers. How can we optimize the services and channelize patients towards the correct line of treatment? So in that sense, how can technology help us do it quickly, safely, and without spending too much money on it? So, so how big is the problem? Like Prashant rightly touched on it. So how big is the problem? So if you look at the problem, the burden of diabetes will mainly fall on people working in the developing countries. So if you look at the graph and the projections for the future, a vast majority of people with diabetes will be clustered around India, China, Southeast Asia, and Middle East. So, and this part of the world is really very ill prepared to tackle this huge volume of cases which is going to hit us in the few years to come. If you look at how bad is the problem, right? If you look at this very informative graph, you will see that the 5-year mortality rates for a person who has had a diabetic foot amputation is more than the combined mortality rates of prostate, breast, and Hodgkin's lymphoma. So it's that bad, and it's a silent killer in the right sense, because so many people lose their lives and limbs, and we don't really talk about it because because we are not aware of how big the issue is. So every 30 seconds, a leg is lost to diabetes somewhere in the world. And if you look at this graph, on the left-hand side of the graph is the 5-year mortality rates for people with various subsets of diabetic foot disease, like a neurovascular disease, neuropathy, or even a peripheral vascular disease. And on the right-hand side, you have the mortality rates for people who have been treated and who haven't been treated. So if you look at the red line, this is the mortality rate for people who have not been treated for diabetic foot complications. And if you follow them over years, you'll realize that the 5-year mortality rate is significantly higher than those in the blue line, those people who have been treated and whose ulcers have got healed. So not only do we save a lot of suffering for the patients, we're actually saving lives in the long run if we can approach and correctly identify the problem at the right time. We don't have any data for India. It's all anecdotal, but we do have data for the US, right? And in the US, the estimated annual US burden of diabetic foot ulcers is at least $15 billion. And the total cost of diabetes is almost $245 billion. And if that's the amount of money that we are looking at US been spending, I'm sure in India with a much higher population, we are at least spending close to that, if not more. And since it's mostly out of pocket, the point being, most of our patients not only are driven to spending a lot of time running into hospitals, but also lose their livelihoods and they lose their life savings in a way. And in a way, a family is almost ruined financially running after saving their limbs. So the real problem, diabetic foot is actually the loss of sensation. And of course, there are other subsets also like peripheral vascular disease, but the vast majority is diabetic peripheral neuropathy. So it is predicted by 2040, there will be almost 640 million people with diabetes in the world. And with the lifetime incidence of foot ulcers occurring in up to 25% of patients, we need to pay far more attention to the diabetic foot and shift our focus maybe to preventing ulcers rather than treating them. So the road from the diabetic foot ulcer to diabetic amputation is not very long. So for a diabetic, the risk of a minor foot injury developing into an ulcer is almost 25%. And more than half of the foot ulcers will require hospitalization. About 20% of them will require surgical amputation. So that's the burden of disease that we're dealing with. And on a lighter note, a landmine claims almost one limb every 30 minutes. And in the same 30 minutes, 60 limbs can be claimed by diabetes. So it's a much bigger problem than we actually see it to be, right? It's not very apparent. So what is the pathogenesis or the pathophysiology of a diabetic foot ulcer? So in diabetes, it's neuropathy, but it's neuropathy as in a motor neuropathy, a sensory neuropathy, as well as an autonomic neuropathy. And all of this together comes together to form a callus, which is basically an area of increased pressure. And from a callus with repetitive minor trauma, you have hemorrhage leading to a foot ulcer. And if you have peripheral artery disease, which is a smaller subset of diabetic foot, you also can have a diabetic foot ulcer without going through the previous stages. So this is basically the pathophysiology of a person with diabetes eventually leads to a diabetic foot ulcer. So what is the way forward? So we need to develop stronger systems to deal with the problem. We need to have a working classification or protocol to deal with the at-risk feet. And there has to be an SOP in every institution to objectively stratify and treat foot at every stage, what we call as a multidisciplinary team approach. But before we go in and build a team, how do we start identifying the people who have problems? Let's start with identifying people who have feet at risk. And how do you do that? What is the diagnostic algorithm which will enable, which will make my life easier and will make the patient's life easier and help us treat them better? So that what we do in Calcutta, and I'm sure in a lot of other parts of the world, we follow the American Diabetic Association classification for at-risk foot. This is basically derived from a classification worked on by the International Working Group on the Diabetic Foot 2019, and they've given us 4 or 5 classifications based on 4 different parameters. The first one being whether the person has any diabetic person has any foot deformity or not, whether he has flat feet, caver's feet, hammered toes, whatever. Second, whether or not he or she has any loss of protective sensation, or whether or not she has any peripheral neuropathy. Third, the presence or absence of peripheral vascular disease. And fourth, the presence or absence of any ulcer currently or a history of amputation or ulcer in the past. So if we can collate all the data at one place and identify the patients and put them and stratify them into these risk categories, we make our lives easier and we make treatment far more easier than it actually far more easier. So how do you do that? There are very tried and tested methods of doing it. One, the very basic thing of doing it, measuring sensation, is basically using the monofilament test. It can be done in the bedside, and you basically assess sensations at the 4 bony prominences on the plantar aspect of the foot, the great toe, and the MTP heads of the 1st, 3rd, and 5th toe. So the diagnosis of neuropathy is established if the patient does not feel 1 out of the 4 areas tested. But the problem with this technique is it's very subjective, as in it's very operator dependent, right? It depends on how much pressure you apply, how long you apply the pressure. So there's a lot of compliance issues with this. The other way of doing it is also to use a vibrotherm or a vibrometer. So this is it's a very automated system. You apply volts or stimulation on the plantar aspect of the foot and check out the various bony prominences of the foot. So anyone who has neuropathy or advanced neuropathy will need actually more than 25 volts of stimulation to register a sense in the plantar aspect of the foot. Between 15 and 25 is moderate, and below 15 is normal. So people who are not diabetic or who don't have neuropathy will respond to a stimulation of less than 15 volts. So anything more than that, you are on the road to neuropathy. This is an ABI-TBI report. This is basically a screening for any vascular disease in the peripheral artery. This is also a very automated report. You don't need someone to stand around and do it. The last and the mechanical part of it is something which is actually very neglected in various, in India actually. We really don't put much emphasis on pressure distribution and structural foot mapping. So this is what we do. We map the pressure areas of the feet and we realize which are the pressure points, which are the areas which are more vulnerable to injury in going forward in a neuropathic feet. And last but not the least, we also do a structural mapping. We want to know whether objectively, whether he or she has any flat foot, any caver's foot, any hammered toes. And this automated system actually picks up any deformity and inputs it into the system. So after taking the information from all those 4 parameters, the sensations, the pressure mapping, the ABI report, as well as the structural mapping, we actually come and give the patient a single pager. This single pager will classify the patient on the basis of the ADA report on the risk category. So suppose on this representative image, the patient has a high risk, so which means he has peripheral artery disease along with neuropathy, which may or may not coexist with a foot deformity. So once we know that the patient has a vascular disease, I can easily refer the patient back to my team member, which in my case could be an interventional radiologist or even the vascular surgeon. So which makes the patient spend less time with me, makes the patient spend less time running around the hospital, and also directs them to the specialist, which can actually save his limb. So once you've diagnosed the problem, once you know which classification the patient falls in, whether it's grade 0, 2, 1, or 5, and you know you're sending him to your colleague who's going to treat you. What about the patients who are grade 0 and 1, which are the major patients which come and see me, the early stages or the incipient neuropathy part? What is the treatment protocol for diabetic foot in the developed world, say in the US, UK, or even in Singapore? What do you do? So what we used to do in the US and the Singapore is that we used to have a lot of Medicare approved customized or semi-customized insoles for those with stage 0, those who are not yet neuropathy, but those who have some foot deformity. So what these contact heat molded insoles do, we call them total contact insoles. What they do, they are contoured along the foot arches, so that when you walk on it with your with the insole inside your shoes, the plantar foot distribution, the plantar pressure distribution is equated, is equal, so that there is no specific area which has more pressures. So it reduces the risk of ulceration going forward. But what happens if you are stage 1? If you have neuropathy, you have an advanced flat foot, you have a callus under the great toe. So for those patients, we need to use a customized insole. What this does, it is basically not only corrects the deformity of the flat foot, it also offloads, say, maybe a callus or the pressure areas, or gives a metatarsal bar, helps equalize the pressure and also correct the deformity in patients who are grade 1, patients who have peripheral neuropathy. One more thing which I want to talk about is diabetic shoes. In India, we talk a lot about diabetic shoes. But what do you mean by diabetic shoe? What are the characteristics or what are the special features of a diabetic shoe? And it varies, right? We all feel a soft shoe is a good diabetic shoe, but that's not really true, right? So there's been a lot of research going on, and this is a result of research from Queensland in Australia, which says that rocker soles, custom-made insoles with metatarsal additions, and a high degree of contact between the insole and the foot reduces plantar pressure in a manner that may reduce ulcer recurrence. So it's all about getting the right insoles, the customized insoles to equalize your pressures, and then putting it in the correct footwear. So that if you are stage 1, you actually help prevent progression of the disease to stage 2, 3, or eventually to an amputation. So this is the best preventive prescription that I as a foot surgeon or my colleagues who are foot surgeons across India can actually give to a diabetic patient with neuropathy. But what happens if you already have a small ulcer? Or what happens if you have Charcot? You know, if you have Charcot, the shape of your foot has changed. You have maybe a small bony protuberance on the plantar aspect of the foot and you can't walk. In those cases, insoles and diabetic shoes really don't work very well. In those cases, you need to have what we call a removable cast walker or air cast boot. These are specifically given to patients who have Charcot foot. And what it does is that a total contact casted diabetic foot orthosis can be used in also a RCW or removable cast walker. And it can also be molded back into the foot so that when the patient walks, there is less pressure on the bony prominences, especially in Charcot, and prevents the breakdown of skin and eventual progression to an ulcer. This is basically for patients in grade 3 and also patients with infected diabetic foot ulcers. So what about those people who also have a big sized foot ulcer, which is not infected? It's a contaminated wound, but it's not obviously pouring pus. So what do you do? What is the gold standard for treating those plantar ulcers? So total contact casting is a very, very old technique. It was basically invented in the 1930s by doctors in the US, and it still is really, really magical way of curing plantar foot ulcers. So what it does is it's basically a special casting technique used to design, it's technique designed to heal diabetic foot ulcers by relieving pressure on the prominent areas of the foot that are prone to skin breakdown and ulceration. So the basic mechanical principle behind the TCC is the increase in weight bearing area. By molding the cast to the contours of the foot, the pressure that was otherwise concentrated over bony prominences becomes distributed over a larger weight bearing area of the plantar aspect of the foot. So it's basically offloading the foot and enabling the body's own healing mechanisms to heal the ulcer. So how do you do total contact casting? This is a small video that I would like to share with my viewers. So this is exactly how we do it. So in step 1, we actually pad the web spaces and put a lot of gauze pieces there so as not to promote sweating. And then you go ahead with the traditional casting technique. You apply a stockinette seal off the mouth of the stockinette there. And then you can use any padding material. It could be foam, it could be gamgee in my case. Anything which is soft and padded can be used in the clinical setting. So you pad the bony prominences, the medial and the lateral malleoli, and also cover the toes. So after you've done that, you apply soft roll to pad up and cover the exposed areas of the calf. And in my case, I usually apply 2 soft rolls to make sure it doesn't break up. And then you use your traditional RT cast or Scotch cast or whatever you may be having in your clinic. And this step is very important. You know, what I do in this step is actually I use a RT cast and make a slab, you know, I make a posterior back slab or a split so that I can reinforce the weight bearing surfaces of the foot so that it doesn't break. Otherwise, it will break over a period of a couple of weeks or a month. And now I'm trying to make the foot into 90 degrees so that he can actually walk with it. Otherwise, if I have some equinus built into it, he won't be able to walk. And this is actually the most important part of what I do in a contact casting. I'm actually trying to mold the arches and mold the plaster to the shape of the foot. You can use the pegs of the plaster cast that you've used and use them and place them under the feet to give a sort of an arch. Mold the heel and mold the forefoot also, and then usually make a fist and press out and mold it flush onto the arches and to the forefoot. You need to have a good assistant to help you out, otherwise it becomes a bit difficult to do it all alone. You can see I'm using my fist to mold it. And at the end of it, I seal off the toe area and give it, and usually make it a one big total contact cast. And once this is done, it's actually sealed off from the environment and nothing can go in. And the patient walks on it, and then you finish it off by folding it and making it look good and comfortable for the patient. This is actually a great way of doing it, and I want to show you some results. This is one lady, and you'll notice she's already had 2 of her toes removed in previous surgery. So she's actually grade 3, and she also again came back with a prominent forefoot ulcer. And this is the native ulcer. This is after 1 total contact cast, and I usually keep the cast for 3 weeks to 1 month. And this is after the second cast. So in 2 casts and in 2 months, the ulcer completely healed. And I did not have to do any surgery. I did not have to do any sort of dressing or any intervention. The only caveat being, you can only apply the total contact cast in a non-infected wound, as in a wound which is not pouring pus. Of course, these wounds are contaminated. These wounds are open, but it should not be a wound with necrosis and a lot of pus. If you have a red healing granulating base like the one here, you can go ahead and cast it without any worries. So the take-home message that is, I would want to convey to the participants and to the viewers here, the big take-home is identify at-risk feet, and you can use technology today which is available and literally screen the patients which are coming to your diabetic clinic or your diabetic foot clinic and classify them. And after you have classified them, you can then channelize them to the proper team member. In my case, it could be the interventional guy. It could be a plastic surgeon. It could be the orthotist. It could be the prosthetist. So it gives you a very nice plan, and you don't have to fumble and don't have to think about what to do. And then once you've given it over to your appropriate team member, of course, they will be treating them appropriately with the current recommendations, which I think my follow-on speakers would be talking about. So thank you so much for your time. If you have any questions, we can take them, or we can wait for the end of the session. So if you don't have any more questions, I think we'll go across and ask our speakers to talk about it.
Yeah. I think that was a wonderful talk. I think you set the note correctly and all, Dr. Kushal, I think for doing wonderful. You've done great justice to your presentation, and I think you made the basic things very, very clear. So I think some great work out there by you. And now if I can share my screen, then I will move on. If there are no questions, then I'll.
So I think I'll request Dr. Bedi to go ahead with his talk on how to enhance wound healing in diabetic foot ulcer. It's a very important topic. A lot of these diabetic foot ulcers are really recalcitrant ulcers, and you know it's really difficult to get them to heal. And I think Dr. Bedi will walk us through what are the modern.
I need to share my screen. I think I'm right now still disabled. So I think the host has to.
Irene?
Have you stopped sharing?
Sharing?
It's been shared.
Yes, I've just
been
shared. I've just shared.
Great. All right. So I think I will just get on to my screen.
Meanwhile, I'll have to take your leave because I have another conference at 3:30. I would have loved to stay, but probably I'll have to take your leave now.
Okay. Right. I hope you can see my screen now.
Yes, we can.
Yeah, we can see your screen.
We can see.
Great. So my topic is being a vascular and endovascular surgeon, how to enhance wound healing in diabetic foot ulcers. A lot of Dr. Kushal Nag has already discussed about the problem of diabetes, which is the new epidemic out here. And this is what he has also alluded to, the number of patients which are there. And what we look at is about 7.3% of patients, or 69% population has diabetes, and 10.3% have, in fact, they are pre-diabetic, and almost 6%, to 14.7%, they are the ones who are foot at risk. And this is something, again, just to reiterate what Dr. Nag has said, up to 25% of those with diabetes will develop a foot ulcer, and an estimated 15% of people with a diabetic foot ulcer will experience an amputation. And once you have an amputation, the mortality goes to almost 50% within 5 years. So I think that is the magnitude of the problem. This, of course, Dr. Nag has again discussed about the various causes of diabetic foot ulcer. Looking at it, a trivial trauma can lead to an ulcer, and that can be either because of neuropathic cause, or it can be because of vascular problem. That means micro and macro angiopathy, and the combination of these two is probably a very bad combination. So when you look at the vascular involvement in diabetes mellitus, you find that the patient can have macroangiopathy. And here, as you can make out, that you literally can visualize the entire artery like a bone. It's absolutely full of calcium and all out here. You can have medial calcification and a pipe stem kind of artery. And this is something we are no strangers to seeing this. The second component which happens in diabetes, and which is the more common one, is the microangiopathy, that you may have palpable pulses, yet you may have wounds which do not really heal. And that is precisely because of the capillary basement membrane thickening, a hyaline arteriolosclerosis, and an increased AV shunting. So as a result of that, the blood basically doesn't really go into the tissue perfusion, but it gets bypassed back into the venous circulation. So that is something that AV shunting happens with these patients. The next component is what are the segments which are affected in patients with diabetes. And as you look into this particular triangle out here, when you look at the age, male and female gender, as well as the diabetics and all, diabetics, the maximum involvement is below the knee vessels, as we call them as the BTK vessels, followed by the popliteal. And then as you go upwards, these are the predominant vessels which are involved, as compared to the patients who have, hypertension, hypercholesterolemia, or who are smokers and all. So there the pyramid totally gets inverted. So the problem in diagnosing arterial disease in diabetics, and that's what Dr. Nag did mention about this one, the ankle brachial index and the diabetic foot, it's a troublesome marriage. The reason is basically that you have these vessels which are absolutely hard as a rock, as I showed you in those images. So even if you do an ABI, you can't really compress these vessels. So the ABI that you get is really, incorrect. And most of the time, the ABI tends to be more than one many a time. So this is a very, very busy slide out here, but generally what Dr. Nag has talked about, looking at the general assessment, the foot examination, screen the ones who are at risk for arterial disease, screen for loss of protective reflex, and then assess the risk which is there, whether they're in low risk, medium risk, and high risk. And then after that, optimize the patient into the correct stream of diseases. Now, diabetic foot disease, unfortunately, is an expensive complication of diabetes. It is disabling. It has a high mortality, as we discussed, and nearly 60 to 70%, 75% amputation can be prevented just by appropriate foot care. And I think this is something which Dr. Nag has shown very clearly in his presentation out here, that looking after the feet, and there's something called in South, they call it what we call the Padukam Puja. They're literally people who have diabetes and all, they are supposed to worship their feet. And the same way that we, look after our feet, our gods, you need to do the same thing for these patients. So a diabetic foot care center needs to treat these patients on a war footing basis. You need to provide good diagnostic, therapeutic, and preventive care of diabetic complications, and arrange the facilities for footwear, as well as domiciliary care for patients with ulcer. Any patient who has an ulcer, it's not possible for him to come to the hospital every day. So you need to provide remote care also for these patients. We have a huge population mass in India, 50% of population in villages with a very poor infrastructure, as you all know, illiteracy, barefoot walking, lack of health insurance, and poor government healthcare services in remote locations is a major challenge in our subset of patients as compared to other countries. So our weapons are education and awareness among diabetic and healthcare professionals, minimal resources to identify the foot at risk, and simple technology for treatment and prevention of diabetic foot care centers. And this is what we discussed just now, that you need to have all these people, a lot of people involved in the foot care. And the most important team member, of course, is the patient. And we look at the foot at risk and the ulcerated feet. I think all these things Dr. Nag has talked about, so I will just go on to looking at this one. Of course, doing a handheld Doppler gives you a fairly good idea as to whether because in most of these patients, because of calcification, you may not be able to feel the pulses. So doing a handheld Doppler or doing an ABI in certain subset of patients will help. And this is again, Dr. Nag has talked about this one. This, of course, is looking at the, TCPO2. We measure the tissue oxygenation level at various levels, and this helps us in deciding whether this foot is going to be salvageable, non-salvageable, whether that patient needs an amputation, if so, at what level. So appropriate level can be chosen by doing the transcutaneous oximetry of the tissues. Well, earlier for a long time, the only options for these patients was subjecting them to large incisions, doing a bypass from the pedal bypass, femoropopliteal, femorodistal bypasses and all. But today, I think a lot of our patients, I would say almost 90% or 95% of the patients can be treated by just doing a percutaneous puncture and angioplasty and stenting. My subsequent colleagues will also be talking about that, but I will just share our experience of a few cases out here. A 60-year-old female, diabetic, hypertension, coronary artery disease, duplex shoulder below the knee disease. An emergency debridement was done, and as you can see, once you clean the wound also, it looks pale granulation, not much of bleeding. So here what we do in these patients is you do an angio and you find that there's a stenosis in the posterior tibial. Down below, the vessel is totally occluded out here. So in these kind of patients, you take a wire across with a catheter, and this is a wire which is going down across the ankle. And then you use a small balloon, 2.5 mm balloon, and then you balloon dilate that segment, balloon dilate the proximal segment. And after that, once you see post-plasty, you can see the vessel, the entire vessel down below is completely opacified out here. So the vessel is opened up, and this is what the wound looks like after cleaning and all. And this is the bleeding which happens with the wound. Another patient, a 70-year-old male, right diabetic foot sepsis, fifth toe gangrene with deep plantar abscess, CKD on hemodialysis, ATA and peroneal were diseased and high counts. Again, doing a debridement, and this is what you see, hardly any, not a drop of blood which comes out. And then you look at that, you find that 2 of the 3 vessels are completely blocked out here. There are multiple lesions out here. Again, going across, checking the blood flow, and you can see some disease in the PTA, but again, you don't have a straight line flow into the artery out here. So we do the PTA angioplasty, you get a very good result out here. Then do the peroneal also. You try to improve the runoff to as many vessels as possible so that at least you are able to improve the blood flow to the foot and salvage this. And now you got 2 vessel runoff clearly out here. And this is what the wound looks like at the end of the procedure. And then after a couple of weeks, you graft this patient, the wound heals well. Another patient, diabetic CAD, low ejection fraction, that's another challenge. A lot of these patients have bad heart conditions. You can't subject them to any invasive procedure. So BTK disease, again, on admission, this is what the thing looks like. A very bad disease out here, BTK segment. We tried coming in from top. We just couldn't go across into any of these vessels. We gave it up on that time. And then after that, what we did a retrograde puncture. This is trying to puncture the dorsalis pedis artery at the ankle. And then once you're able to cross, you'll go a retrograde access. And then you snare your wire upstairs, get it out there into the catheter, which is lying out there on top. And then through that, you make an exchange, you do a wire flossing. And then you're able to get your wire down into the lesion, balloon it nicely, get your blood flow. You can see all these tight lesions which are there, and you got nice straight line flow across the ankle. And this is the final result. The patient skin grafted after a week and the wound heals well. Another patient, again, diabetic. And this is the kind of wound. Now, I think a lot of people would agree that these are the patients who probably, without a thought, a lot of surgeons would say that let's do this below knee amputation in these kind of patients, because this foot is not really worth salvageable, because you've got disease and a wound which is going across the ankle. But to find that there's a SFA disease, superficial femoral artery is completely blocked out here. You are only seeing a profunda, and this is where the reformation is. So again, you go up from top, go with a loop wire balloon technique and get across, and you got a straight line flow into this one, except there are some dissections. You put in a stent out there, a long stent out here. Once you get the flow down, you got an artery completely which is reconstituted, and you got a nice straight line flow into the patient. And this is what the wound looks like at the end of the procedure. And this is the final outcome of this wound. So I think 9 out of 10 people would probably do an amputation for this patient. Another one, uncontrolled diabetes, HbA1c of 11, low ejection fraction, severe sepsis, bilateral iliac artery diseases, which are relatively uncommon, but there's a combination of atherosclerosis. Again, on presentation, this is the kind of wound that you're looking at. And here, when you do an angiography out here, you see that there's a total occlusion of the iliac artery on both the sides, extending into the aorta. So then, of course, you go up from top as well as down below, reconstruct, just putting in 2 kissing stents. You restored the flow, just do a balloon plasty out here, and you got excellent flow going down. And this is what the wound heals primarily just by secondary suturing, by primary closure. And then again, another wound which is there, which you can see a hot, foul-smelling foot with leg abscess and all. And this is again another patient who probably most of the people would consider doing an amputation. But here you find an SFA stenosis and find some distal vessel disease also in the below the knee segment. And in the anterior tibial also, you balloon all of them. We try to open up as many vessels and all that we can and do a complete plasty of the whole thing. And then after that, you can see the final outcome. You corrected all the levels of the disease, got a good straight line flow from the anterior tibial, you got flow across the ankle now. And this is the wound which looks after that. And this wound was completely salvaged. We used skin graft and all. After that, the wound is healed. So now coming to some other procedures which are being done, ultrasound wound ebrima. You have certain techniques which are there for patients who have the large ulcers, which are very, very painful and all. You can use an ultrasonic machine which cleans out the wound with a spray of jet out there. And this is one way of cleaning the wound with a Versa jet out here, and then follow it up with what we call the vacuum assisted closure. This is something which has become the mainstay of our patients who are with diabetic foot ulcers. And then the latest kid on the block is basically using the Integra dermal template, which is their regeneration template. This is a layer of artificial dermis which is applied on cleaning the wound. And here, as you can see, these are some of the wounds which were there. And then after that, you clean the wounds. And then after that, you apply the IDRT. And this is what the IDRT, as we call it, the dermal regeneration template, which is applied out there, which is a dermal technique. And here, once you apply it, you give VAC for about 3 weeks. After that, you have a nice bed out there and you skin graft the entire wound. It's got such a stable platform. Another patient who has had a IDRT applied out here. Again, another one, and here this is such a false looking wound out here. And you would think that this wound would probably never really heal. And after that, when you look at this wound, this is what the wound looks like after a few weeks. So these are some of the new things which have happened out here. And many of these patients would probably have a major amputation. But I think today, with all these techniques, we are able to salvage most of these ones. So IDRT is proving to be an excellent modality in treatment diabetic foot ulcers. However, one must ensure adequate vascularity to the wound and eliminate any infection before application of the IDRT, because otherwise if you apply it in the presence of infection, then in that case the wounds will never really heal, they'll get infected again. And one can clean the wound partially if there's any discharge observed while changing vac, but the results are better and faster if the bed is clean. Another observation is that in the feet and more towards the sole, the skin graft is very smooth without any wrinkles, whereas application of SSG in non-IDRT patients shows numerous wrinkles and unstable graft, and you can have an ulceration again in these patients. Again, there is a role of using in certain patients with non-reconstructible lesions. You can use hyperbaric oxygen, vasoconstriction, all these techniques which are there with hyperbaric oxygen. Giving oxygen under high pressure does tend to heal. Dr. Nag has already spoken about this one. And this is one of the last part that I'm going to share, mobile services. I think today in our country, the major problem is patients can't reach you many a time. So we have to have a system where we can reach the patient rather than the patient coming to you. And this helps in reducing the cost of manpower. Where this template, I borrowed these slides from my friends in Jain Institute of Vascular Sciences in Bangalore, where they have a foundation which is being funded by the World Diabetic Foundation, where the driver is trained to perform dressings. There's a weekly schedule where the van goes to each designated village, town, and visits each patient, and drugs and dressings are provided to the patient. And this is what it looks like. A driver who goes there, he does all the dressings and comes back every day. He's got a different schedule. This is one way. So coming to the end of my presentation, the take-home message is the leg is often lightly, it's taken very lightly. Amputations are being done when the leg could have been saved. The physical and psychological impact of a major amputation are underestimated. Not every septic foot needs a major amputation. We have salvaged many a foot which was destined to be amputated. As I showed you in my slide set, a careful patient assessment is mandatory in all cases, and vascular disease can most often be corrected, and that too using minimally invasive endovascular techniques, thereby achieving a limb salvage as illustrated in the cases described above. With this, I come to the end of my presentation, and I bring warm regards and greetings from my team in Sir Gangaram Hospital, which is right now the largest vascular surgery center in the country. Thank you very much.
Thank you, Dr. Bedi, for this wonderful presentation. It was great to see how over a period of the last decade, technology has changed so much, and how, as you had rightly put in, how we're currently saving legs which would have otherwise amputated maybe a decade ago. So it's a fantastic presentation, especially the endovascular interventions that really have been a game changer in the way we look at diabetic feet. So I think we'll have do we have any questions coming in the chat box? Anybody? I don't think we have any questions.
No, we don't have any questions.
Okay.
So without wasting any more time, I'd like to invite Dr. Edward Chok. Dr. Chok, our guest from Singapore General Hospital, would be talking on management of diabetic foot wounds. So Dr. Chok, over to you.
Hi. Thank you very much for the invitation to talk in this webinar symposium. Truly honored to be part of such esteemed colleagues, and I really enjoyed the previous two presentations. So I am Edward Chok. I'm a consultant at Sengkang General Hospital from Singapore. I'm a vascular surgeon, and my topic is on the management of diabetic wounds. So diabetic foot disease, as you've heard from Dr. Nag, is a major problem worldwide. It is amongst the most serious complications of diabetes. It causes major suffering and financial costs for the patient. It causes considerable burden on the patient's family, healthcare professionals, facilities, and society in general. So in Singapore, we are a small country and we are generally a very peaceful country. So it takes a lot for us to wage a war. In fact, our government has waged a war on diabetes, and this was back in 2016, because diabetes is so prevalent, it's causing so many problems, and diabetic foot ulcers are one of the major problems with diabetes, with diabetes at the moment in Singapore. So what are the majority of my talk today is based on the International Working Group on the Diabetic Foot Guidelines, which was published only a few months ago in 2019. The International Working Group on the Diabetic Foot meets every 4 years. They have a international symposium, and I was fortunate enough to be able to attend their symposium in The Hague last year. They provide very good guidelines, for example, on the prevention of diabetic foot ulcers, how to offload, how to treat peripheral arterial disease in diabetic foot ulcers, how to treat the infection, and also on various wound healing interventions in terms of their recommendations. So basically, pathophysiology of diabetic foot ulcers can vary in terms of prevalence and spectrum in different parts of the world. However, the pathways to ulcerations are always similar. The majority of these are always involved with diabetic peripheral neuropathy in some way or other. Plus, minus, some of them may have peripheral arterial disease, and that's where vascular surgeons come into play. So neuropathy leads to an insensitive foot and sometimes deformed foot, leads to abnormal loading of the foot, and even a minor trauma can precipitate ulceration of the foot, such as from ill-fitting shoes or from acute mechanical or thermal injury. In terms of how the ulcer develops from repetitive or excessive mechanical stress, first you have the loss of the protective sensation, foot deformities, and limited joint mobility, which results in abnormal biomechanical loading of the foot. This produces a high mechanical stress in some areas, and the response is usually a thickened skin, otherwise also called a callus. From here, the callus then leads to a further increase in the loading of the foot, often with subcutaneous hemorrhage and eventually skin ulceration. And finally, whatever the primary cause of the ulceration, continued walking on the insensitive foot impairs the healing of the ulcer. So this is the vicious cycle that causes the diabetic foot ulcer. The other component of diabetic foot ulcers is peripheral arterial disease. So atherosclerosis is present in up to 50% of patients with diabetic foot ulcers. However, only a small percentage of foot ulcers in patients with severe PAD are purely ischemic in diabetic patients. The majority of diabetic foot ulcers are either purely neuropathic or they are neuroischemic. That means they've got a combination of neuropathy and ischemia. So it's must, as a vascular surgeon, we always must think, of the neuropathic component of the diabetic foot ulcer. So these are the 6 principles of diabetic foot ulcer treatment as proposed by the International Working Group. First, you must pressure offload and protect the ulcer. Secondly, you restore the tissue perfusion. Thirdly, you treat the infection. Fourth, you must control the metabolic problems and other comorbidities that these patients usually have. Fifth, there must be meticulous local ulcer wound care. And you must not forget the last, which is education for patient and relatives. So I'm going to go through each of these 6 points in a bit more detail. So Dr. Nag has already gone through a brilliant video on how he performs a total contact cast. So pressure offloading and ulcer protection. Offloading is the cornerstone of any diabetic foot ulcer management. This is particularly most important for ulcers that are caused by increased biomechanical stress. So neuropathic plantar ulcers can be treated by non-removable knee-high offloading device, such as the total contact cast. What about for heel ulcers? And this is a patient that's currently in my ward at the moment. For heel ulcers, what we normally do in our hospital is a cheap way, which is we use 2 things. Firstly, and this is a picture taken this morning of this patient, I use a pillow to elevate their leg. And secondly, I also apply heel cushion to the heel ulcer. And normally we put them in this position in the hospital. And when they go home, we also must educate them to maintain this position whenever they're lying in bed and to totally, strictly offload the heel from any pressure at all. Secondly, we restore tissue perfusion and we consider revascularization if the ankle pressure is less than 50 millimeters mercury, if the ABI is less than 0.5, but you've heard that ABI is really not a really good measurement for diabetic foot ulcers because they are usually calcified, so ABIs can overestimate. So the thing which we use in Singapore is toe pressure, and we consider definitely revascularizing them if toe pressure is less than 30. However, for practical purposes, in my practice, I will consider revascularization in any toe pressure which is less than 60 millimeters mercury. Okay, and also when an ulcer fails to show signs of healing within 6 weeks, even if you've got a good toe pressure, then we'll also consider doing at least an angiogram, maybe optimizing their vascularity in patients with slow wound healing. This is a publication from the European Journal of Vascular and Endovascular Surgeons in 2017 on the guidelines on the management of peripheral arterial disease. And it is a busy algorithm, but basically I want to draw your attention to the fact that this is an algorithm that kinds of guides us as to whether we perform endovascular first or bypass first. But I'm not sure about, you'll probably share the same thing with me. In terms of diabetic foot ulcers, it's completely different kettle of fish. In this instance, they talk about whether it's a stenotic lesions, then you go for endovascular first. If it's a long occlusion, you perform bypass first. However, for diabetic foot ulcers, in terms of vascularity, I find that in my practice, almost all of these patients undergo endovascular first because we're dealing with below the knee, very small arteries which are not amenable to any bypass. I can remember maybe doing 2 bypasses for diabetic foot ulcers in the last 1 or 2 years alone. So this is how we aim to revascularize. We aim to restore direct flow to at least one of the foot arteries, preferably the artery that supplies the anatomical region of the wound. So this is a patient which was had an angioplasty about 9 months ago, severe below the knee disease of both the anterior and posterior tibial arteries with long CTOs. And when you look at the foot run, the majority of the flow is from the peroneal artery, very little flow from the anterior tibial and the posterior tibial artery. We perform angioplasty using plain old balloon angioplasty, and then we also use the Magic Touch sirolimus coated balloon to try and increase the durability of the patency of the vessels. So we angioplasty the distal and the proximal extent of the arteries, and then we try and achieve as good as flow as possible flow to the foot, preferably the artery that supplies the anatomical region of the wound. So in this instance, we try and achieve a good 3-vessel runoff to the foot to try and optimize the chance of healing of the wound. However, we also must consider, Dr. Bedi has shown us brilliant examples of cases, amazing vascularity, amazing foot care leading to ultimately limb salvage. However, in some, we must accept that either patients are too sick or their foot are too far gone. We avoid revascularizations in these patients in whom the risk-benefit ratio for the probability of success is unfavorable. Thirdly, treatment of infection. You must be meticulous in terms of cleansing, debriding all necrotic tissues surrounding callus. We start all our patients on empirical oral antibiotic therapy the moment they get admitted to hospital. Usually we start them with IV augmentin. For patients who are a little bit more septic, we consider giving them IV tazocine. We target primarily at Staphylococcus aureus or streptococci, unless if there are other reasons to consider other likely pathogens. For example, in green wounds, we consider Pseudomonas. Then in 3 days, when we get our cultures, we adjust the antibiotic regimen based on the culture and the sensitivity results, and also based on the clinical response to the empirical therapy. Fourthly, we involve our cardiology colleagues, our endocrine colleagues, our internal physicians, because we consider this to be a holistic program. We must control their metabolic problems, we treat their comorbidities, we identify what medical conditions need treating. For example, we optimize their glycemic control if necessary with insulin. We treat any edema, anemia, or malnutrition if present. Fifthly, local wound care is of utmost importance. We regularly inspect the ulcer, and the frequency will depend on the severity of the ulcer, the underlying pathology, the amount of infection, and the amount of exudation. As a general rule, they stay in hospital until they develop granulation tissue until we think we can manage them on an outpatient basis, then we discharge them. We debride the ulcer and repeat as necessary in the ward or in the operating theater. We select dressings and we balance it out to control any excess exudate. And we also must balance against desiccation, so we maintain a moist environment. We never ever soak the feet, as this may lead to maceration. And we consider vacuum dressing as shown by Dr. Bedi, because negative pressure with vacuum dressing is the cornerstone of any management of diabetic foot ulcers. In terms of adjunctive therapy, we consider in non-infective ulcers that fail to heal after 4 to 6 weeks, a sucrose octasulfate impregnated dressing, or a multi-layered patch of autologous leukocytes, platelets, and fibrin. Sometimes we don't really use this in our hospital, but it's been recommended in the International Working Group, placental membrane allografts, and also hyperbaric oxygen as demonstrated by Dr. Bedi earlier on. In terms of what is not well supported, the International Working Group suggests that these are not well supported: biological active products, collagen, growth factors, bioengineered tissues, or silver, or any other antimicrobial agents containing dressings or topical applications. Number 6, education for patients and relatives are very important. We always take the time when they're in hospital, we bring their family in, because they spend about 1 to 2 weeks with us. So we bring them in and we instruct them and the family on appropriate foot ulcer self-care, how to recognize and report signs and symptoms of new or worsening infection, any fever, changes in the local wound conditions, worsening hyperglycemia. And during this period of enforced bed rest in our hospital, we instruct them how to prevent an ulcer on the other leg. In terms of the organization of care for diabetic foot disease, this is fully dependent on a well-organized team. It is a team effort. It is a holistic effort in which the ulcer is seen as a sign of a multi-organ disease, and we integrate the various disciplines within our hospital. So effective organization requires systems and guidelines for education, screening, risk reduction, treatment, and auditing. In our hospital, we practice a level 2 level of care. We have got a diabetic specialist, the vascular surgeons, both vascular surgeons, orthopedic foot surgeons, vascular specialists who have expertise in endovascular and open revascularization. We have infectious disease specialists. We have a team of podiatrists, and we have a specialist diabetes nurse in collaboration with our orthotists or prosthesis. In our hospital, we call this the holistic care for peripheral vascular disease. This is the HOPE program. And in this HOPE program, we envisage the whole journey of the patient involving the integration of multiple specialties. So from the day of admission, we involve our internal medicine physicians, our cardiologists, and our diabetologists. First of all, to optimize their medical comorbidities, to make sure that they are safe for revascularization, and also to try and modify their metabolic comorbidities from day 1 as soon as possible. From day 1 to 3, we try and revascularize their wound if they need revascularization, and we do this as soon as possible. And at the same time, we will also aim at controlling the infection by debridement of the wound. Day 1 to 20, we involve our podiatrists in our daily ward rounds. Our vascular nurse specialists or infectious disease specialists comes in and optimize their antibiotic regimen. Our internal medicine physicians continue to see them on a daily basis to try and make sure their medical comorbidities are all optimized. And then our rehab physicians come into play at about day 5 to try and coordinate their discharge and rehab. They normally step down in the community hospital where they continue to receive care on their wounds and on their general medical comorbidities. So this is our holistic care pathway program. We also have the DREAM program, which is basically it's short for Diabetes Rapid Evaluation of Lower Extremity Amputation Management. Basically, we want to catch them at the earliest stage possible, because the earlier we catch them, obviously the chances of a more positive outcome is much, much better. So you want to catch them when they only have a little toe ulcer, and we don't want to catch them when they present with gangrene of the whole foot, and rather for 6 diabetic foot like the one on the right side. So in terms of the DREAM clinic, this is the setup. It's a walk-in clinic where patients can walk in anytime they want between the hours of 8 and 6 p.m. They can come in from A&E, they can come in from polyclinic, and they're seen firstly by the podiatrist. And so from the podiatrist, then they are triaged into whether they are an orthopedic diabetic foot wound, or they are medical diabetic foot wound, or whether they are a vascular diabetic foot wound, all dependent on whether they've got a foot pulse or they don't have a foot pulse. So this is basically the whole premise of our dream clinic, to try and identify them as quickly as possible. So in conclusion, the six things need to come together like a jigsaw in order to try and achieve the best possible outcome: pressure offloading, restoration of tissue perfusion, treatment of infection, metabolic control, treatment of comorbidities, meticulous local ulcer care, education, and it's all a team effort. Thank you very much.
Thank you, Dr. Chok, for this wonderful presentation. I think the biggest takeaway from this presentation of yours is the robust team that you guys have in Singapore, and the amount of time and effort that you spend to triage and identify at-risk patients. I think something that we in India are also doing, but we need to do more in a way, and hopefully save more limbs as we go along. Do we have any questions in the chat box? I don't see any.
No, we don't have as of now.
So then I'll hand over the presentation to Dr. Seth. I think Dr. Seth, thank you for your patience, and we'd be happy to have you share your screen.
Can you see my screen?
Yeah, we can see it, Rahul.
Yeah,
we can see it.
Thank you. So we got excellent presentations from Dr. Chok and Dr. Bedi, and I was a little concerned that maybe me being the IR, I'll overlap quite a lot, but I think we've all seen these dirty feet, which all have been shown regularly. But what I thought that let's talk about a little of the practical aspects of diabetic foot. So these are the slides, although we are seeing a raging pandemic going on right now all over the world. But remember that every 30 minutes a limb is lost due to landmines, but every 20 seconds a limb is lost due to diabetes. So please remember that the diabetic foot, in my terms, should be termed also as a pandemic. And we should be treating that as urgently as we are tackling many other things going on right now. We have definitely progressed dramatically from what has been happening since the early 19th century. This actually was the treatment of diabetic foot, basically just chopping off the leg, and in a very gruesome, gross manner, which was being done. And as rightly said by all the speakers, it's a common occurrence. It's not as uncommon as we think. It's extremely complicated to treat. It requires a multi-speciality team which is involved, and it is a costly issue. Why am I saying costly? Because diabetic foot on people's life is devastating. So you're looking at nearly 10% of the yearly income on diabetes is spent for insulin, medications, blood tests, various complications arising from it. But a diabetic foot ulcer or a diabetic foot infection, people nearly land up spending 50% of their or hers yearly income. So what is it defined? We all know that it's severe limb ischemia. You have nearly 40% of extremities with ischemic non-healing ulcers, rest pain will require a major amputation. And that is what this whole talk or this whole concept is about, is how we are trying to avoid amputations for diabetic foot and basically get people back to work, back to leading their normal lives and having a life of at least less morbidity and actually as normal as we can try and get them. So what are the basic principles which we look at? I think it's all been adhered to by the previous speaker, so I won't get into too much detail, but just give you a general overview. Is basically assess the neuropathy, because diabetes not only affects the blood vessels, it also affects the nerves. And basically assess the neuropathy, the altered biomechanics, assess the blood vessels, which has been beautifully portrayed in the last two speakers. And I think Dr. Nag also has shown exactly about diabetic foot, how things were. Debridement and wound care, footwear management, and how do you prevent any things happening occur. For those people who are seeing, these are these really gruesome sort of pictures. If you look at, for those who are non-medicals, you feel like, oh my God, what do these doctors do? Are they doctors or are they butchers? Actually, are they going to see? But remember, it's when you see a toe like this, a lot of patients come with a toe like this and they say, but doctor, we only have a very small toe problem. Why are you advising so many complicated procedures to us? And, it takes time for us to explain to them. But when you say these are icebergs, as you look at an iceberg, you see this is actually when you see how deep the infection can go down. So what looks like just a small toe infection here, when you actually assess, it's actually gone all the way down into the heel area, gone all the way down to one side, and this whole area was infected. So just don't think that this is a very small thing and doctors are out to unnecessarily do procedures on you. This is actually what we are dealing with, and that's what we need to tackle to try and save your foot. Now remember, when you are having diabetes, the basic thing is you don't have a great sensation on the foot. And when you wear various types of fancy shoes and all those things, they have repetitive injuries which can occur, and that can cause pressure and can cause calluses, and that can lead to diabetic foot ulcers. So what is the myth? The myth is that amputations from diabetic foot infections are inevitable. It means any patient coming with a diabetic foot infection, people say, whatever they do, you're going to lose your leg. No. Early, aggressive, and targeted treatment can save toes and limbs, like what we are trying to do. So very small thing is that, when patients come into a lot of physicians' clinics, they come with their feet. No one even looks at the feet because feet are supposed to be the most ignored things. But all you need to do is have a sensible hands and eyes and look at the feet. You see the way the patient is walking into your clinic, if they have any type of special gait which is causing it, or they are limping. And then when you when you take out the shoes and you exactly look at the feet, examine the feet in great detail, and you'll come to know a lot of problems which are there. So we also obviously go by the basic examination of the duration of diabetes, the nature of injury, and most importantly, when you're going to your local physician, please ask them, if they don't, to check the pulses in the feet also, because if you have good pulses, you're dealing with a neuropathic foot. If you don't have good pulses, you can deal either with neuropathic with ischemic foot also. So, and local examination has to be done. And that's what we are doing right now in our diabetic foot clinics also. These are all things I won't go into much detail. It's not the forum for it, but all these things need to be looked at. Like if your nails are brittle, then during the neuropathy, there is an infection within your feet. You're not, the patient is not keeping the feet clean. You can have a fungal infection which can spread. Calluses and corns, all these things have to be assessed. And this is what normally we see in diabetics, although this is a neuropathic problem, but we see all these problems occurring when patients come into our clinic, and we need to keep a watch on them, because it's not that every patient has got a vascular problem. Some can also have, a lot of them also have neuropathic problems, and we need to tackle those two simultaneously. So this is a busy slide here, but you can see that it's a 3-minute diabetic foot examination. So what I would, this is a very, very nice slide, and you can look at it that if the patient has a previous ulcer, a previous history of these problems, if they have any dermatological, neurological, vascular examination, what are the recommendations for daily foot care? That's what we need to teach our patients, what type of foot care. So in this whole thing basically tells you how we basically need to manage a patient with diabetic foot. Investigations, a lot of patients come to us sometimes late, and they come to us with various types of investigations. There's a color Doppler, there's an MRI, so some patients even come with a heart angio, some patients come with CT angios. So we are trying to, in our diabetic foot setup here in Mumbai, we are trying to see that how we can reduce unnecessary investigations and only do investigations which are targeted for diabetic foot. Basic investigations, obviously from the blood investigations, require the blood test, which is the CBC, the kidney profile, because a lot of patients are nephropathic, so we need to look at their kidney profile too. We need to see if there are any infections, which is the CRP. And then when we get, these are the basic tools, I think very nicely said by the previous speakers. So the ABI machine, you need to look at the neuropathic and the vasculopathic evaluation by various tests. And what I would stress on is that once you have done a good clinical examination, in our minds, we have already got sort of a diagnosis of what the problem is and what we are needing to do. So what we refer, at least what we do in our practice, is refer the patient for a color Doppler of the arterial system, because we are suspecting it's an arterial problem when you're dealing with peripheral vascular disease. And we avoid CT angios and MR angios in these patients. One, the reason we avoid them, because a lot of patients have got kidney issues pre-existing. We don't want to subject them to all these unnecessary investigations of high contrast. Plus, they do put a strain on the heart, especially CT angios when you're using some type of contrast media. So our plan is do a color Doppler, do a good clinical examination, a good color Doppler, and directly go ahead with the treatment, like which has been alluded by the previous speakers of doing an angioplasty and a stenting. The other treatment which we always start all our patients on are basic antiplatelets. We start on dual antiplatelets if the patients are going to require any intervention. In our practice, we don't use silestazole too much for diabetic foots, but we mainly use it for patients who are claudicants. Obviously, the anti-diabetic sugars have to be well controlled. The statins have to be started if patients have high cholesterol. A good antibiotic has to be given to prevent any infection, or if there's an ongoing infection, to reduce the infection. And we are not big fans of these vasodilators like Trental and Complam actually in our practice, although it's rampantly given by physicians all over the city. But at least when they come to us, I basically throw these medicines out in the dustbin when they come, at least to me. So what we need to do is basically get the blood flow back. And like how Dr. Bedi and Dr. Chok rightly said, is that earlier it was to be surgery used to be the mainstay of treatment. And now endovascular means angioplasty, stenting, and sometimes even giving a clot busting drug if it's an acute block are the ones which we use as the mainstay. But yes, surgery should not ever be ruled out. Sometimes you can have a combination of both. You can do combination of endovascular and surgery. The main aim is do what you know best and how you, or refer to someone who what knows best, but try and salvage the foot. Basic chart which is there, what we are trying to do is get the patient back as normal as possible. And what we are trying to do is avoid stage 4 in this. Basically, we are trying to see how we can reduce the amputations in these patients and try and get the patients back to normal life. So a few cases, I think all have been, the earlier speakers showed all on below knee intervention. So I will not talk too much about that. This is basically one of the few times we got a CT angio done because we're dealing with the patient who has something called claudication, not classically diabetic foot. But here what we have done is, this used to be a patient who had a block in the main aorta blood vessel which is there. And here what we have done is put in a balloon and put in stents and gone through and got this artery completely open, as you can see here. Earlier this would require a major surgery by opening up the abdomen or cutting up the abdomen, but now within a day of, sometimes in these procedures, we can sort of do it in the morning, send the patients home in the evening, or worst comes to us, send them home the next morning and they're back to normal activity within a couple of days. So this is a very interesting case which we had done. Is an 88-year-old man. They had non-healing ulcer on the great toe 6 years back. Someone outside had tried an angioplasty, but they couldn't get through the block because there's a long block of the main artery in the thigh called the superficial femoral artery. They did a femoral popliteal bypass. Everything did well, no problems, recovered. The foot healed well. But now on the 4th and 5th toe of the left leg, the same leg, there was a block and the graft had occluded. In the interim period, this poor gentleman had got a fracture neck femur, so not a good candidate for a redo bypass. But in these days, so in the 21st century, and especially in 2020, we don't shy away from even arteries which are completely blocked like this, coming all the way down. And you can see a long segment block in the thigh. You can see the previous surgical clips here, my arrows are showing it. But even when with better understanding skills, the wires were earlier, take that out. Wires are not the same. The wires have definitely improved. We have got excellent wires which come now. A wire is the thing which basically uses to go. We have plaque excision devices like this, which remove the plaque. We have long balloons. We have drug-eluting balloons. All these things are there in our arsenal now. And we do whatever we can to get this artery open, and we have done it. We've got the artery open all the way down. In this case, we have put stents. Sometimes we don't even put stents now. We use a plaque excision devices and drug-eluting balloons, and we get this artery open. How we do it does not matter. We need to get the blood flow to get the foot healed, and this foot healed very well. Although in India, drug-eluting stents came and sort of disappeared for some DCGI reason, they are still doing a very good job all over the world. Hopefully we'll get them back soon. And they also have got good results to keep the arteries open. This is another case which is now looking at using stents which go across the joint also. So earlier the bugbear of endovascular intervention was not using, not going across the joints, meaning the hip joint and the knee joint. But in this case, we've even managed to go across the joint with special stents which are flexible. Here, this is coming now below the knee, a 71-year-old lady, non-healing ulcer on the right foot. You can see very poor blood supply. There's a block in the artery across the knee joint and very, very poor. This black denotes the blood supply here, the blood flow, but very, very poor flow all the way down in the foot. And nowadays, we genuinely, as all shown by the previous speakers, no one shies from going down all the way in the foot. We put in stents even across the knee joints, and we need to get flow. Similar cases, I won't waste your time too much on this, but these are very diffuse long segment diseases, and we need to get things open so we can use long balloons. We have balloons now going up to 30 centimeters. We've got drug-eluting stents also which are used in the arteries. And our idea is get the flow down It should be durable enough, at least for 3 to 6 months, to get the wound healed. That is our main idea. Get the wound healed, get the patient back to normal activity. A lot of patients ask us, even some physicians ask us, but how long will this artery remain open? Are you going to give us 2 years, 3 years? I said, here we are not concerned when you're coming below the knee. We are not concerned about if the artery remain opens for 3 or 4 years. If it does, we'll be very happy. We are looking at how to salvage the foot and get the blood flow down and heal the leg completely. That's our main concern. So here, in this case, we look at limb salvage, means how we can save the legs. And as said before, that it's a team effort. It's not only once I do my job, the job is done and I will not look at it. We have the diabetic foot surgeons who come into play, and they play a very, 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 very integral part of the whole thing. The podiatrists, the people who manufacture the footwear, the foot mapping, all shown by Dr. Nag very well. And you, as I said, you require patience. It's not something where if I do the, if someone does a treatment today, by tomorrow they're going to get better. It can take good 6 weeks to 8 weeks, in sometimes 2.5 to 3 months of feet to heal. Sometimes you may require to re-intervene again in an angioplasty. You can have an acute closure. So you should prepare your patients for all these things, explain to them, counsel them very well, and then we can achieve results of healing the foot. Most importantly, a lot of patients feel that once you have done these procedures and once everything has been done, they're ready to walk. But no, it's basically until the wound heals, you need to offload. Offload means get the feet up. You cannot go for walks. A lot of people advise go for walks after this. You're not supposed to do all that. So you need to follow the counseling or the foot, what the diabetic foot surgeon tells you in great detail. For the physicians who are on this talk, remember there are certain agents which are being used regularly in general practice. And these are things that actually delay the wound healing in diabetes, like steroids. People use Usol solution, chlorhexidine, hydrogen peroxide. All these things should not be used when you're using diabetic foot. And you require to do the ideal method of dressing is irrigated sterile saline. This is shared to me by one of the senior most diabetic foot surgeons in the country, Dr. Arun Bal. I work with him in great detail. We are a good team effort. And this is all the things which he has taught us. And we also educate a lot of physicians. And you can use a paraffin gauze or an antibacterial ointment, reduce the colonization and get the foot healed. And this is what we are trying to do, that we explain to the patient that this is a bad ulcer. You can see you will lose these 4 toes, definitely in cases like this. Obviously, we feel bad if even taking out these 4 toes. But these are patients who, once the wound heals like this, the patient can walk. And that is what the most important is. With the right shoes, with the right thing, the patients can walk. Otherwise, maybe 30 years back, with a wound like this, after maybe 6 months, they will end up with a below knee amputation. And that's what, or even an above knee amputation. And that's what we have been successful in avoiding. And even now, the patients come earlier. If they come earlier, we can even avoid getting the toes off. And that is what the whole idea is in diabetic foot. And footwear is the cornerstone of primary and secondary prevention. That's what Dr. Nag has very beautifully put it out. I won't go into great detail. He has given all the offloading and all the shoes which are there. So they do sometimes look ugly for patients, but remember, ugly equals beautiful in diabetic foot. You need to get the right shoes. Don't bother how they look. A lot of patients tell me, doctor, these shoes are so ugly. I said, well, it's better to have ugly shoes than have no shoes at all. And that's what is something what we require to be done. So methods of offloading, I'm definitely not going to go in detail, but the various types of offloading, insoles which have been there, special type of offloading to keep the feet off. This has to be done with strictly, it has to be instructed to the patients very well. And you can see that this is a series which was published years back by us. We were struggling at a 60% limb salvage rate in India. This was nearly, I would say, 15 years back. And but now we have managed to go up to 83, and now even this is 2015 data, we have gone up to 83%, and 2020 data within a short span of 5 years, we have literally managed to save now nearly 90% of the feet all over the country. And I think that's basically because of the way the speakers have beautifully said, marked improvement in diagnosis, people are coming early, although still in India, the rural population, this does tend to come in late, but yes, awareness is definitely increasing. We are getting aggressive medically and endovascularly. Foot care is being aggressively pushed to the patients. Follow-up is being done. Foot mapping with shoes and everything has been done. And now from 83%, we have gone up to nearly 90% of limb salvage. And that's what we are going to try and do now. We have coronary care units all over the world, stroke units all over the world, but now we need something called foot clinics, and that's what we have done. And you can, Dr. Chok has rightly said, Dr. Bedi has beautifully put it, and Dr. Nag has put that it's not just one person who does the job, it's a team effort. And without this team, you will not be able to save the foot. So the 10 commandments which I like to end this talk with is: do not walk barefoot. In India, we need to try and educate more and more patients that please do not walk barefoot. Inspect the feet daily for blisters, wounds, and bleeding and warm, especially for diabetics. How we are constantly checking a pulse oximeter saturation in this era of corona pandemic. Please try and also check the feet for diabetic foot patients. Don't ask patients to use hot fomentation and cold packs and strong ointments. I've seen patients doing vigorous massages with these various oils and going deep. Footwear has to be put right for the feet. Don't try and wear fancy footwear which does not help you. Don't walk on the affected weight-bearing foot. Don't sit cross-legged for a long time, especially in our country. Do not remove footwear during travel. God knows where you get injured, what happens. And I've seen patients literally having to cut across their vacations and come running down back to our country because they've got diabetic foot and they get an infect. Clean the feet regularly. Do not cut corn and calluses, and cut the nails regularly and trim square and not go too deep and pinch the skin. So these are the feet crying out to you. How Dr. Bedi beautifully put that picture in Kerala, that all we have to pray with the feet. And I completely agree. These are the feet crying out, save me, please. And we need to save them. Thank you so much.
Thank you, Dr. Seth. Wonderful presentation. I think the biggest takeaway from all of this is that you have the expertise, and over a period of time, we're getting newer technologies like Dr. Seth mentioned, long segment disease, bigger balloons, smaller stents, and stents across joints. This will eventually evolve to better technology. But I think the key message is get awareness out to people. Like Dr. Bedi said, get people out into the rural areas, train your primary physicians, train the dermatologists. So if you can get like-minded people together, I think this will, we can save more limbs and we can save more money, more money in the sense of patients can save more money and not, run from pillar to post. So I think wonderful learning experience. I mean, it's amazing the way interventional radiology has changed. So one small question, is there still any role for conventional vascular surgery? I don't think there is anymore, is it?
No, I think there is still a role of conventional vascular surgery, because when you look at it, we have a lot of patients who are early onset diabetics, who are in their 30s and 40s and all. They are basically good patients who need a, patency and all of, or patency of the distal vessel for a much longer period. When we are doing all these patients that I think all three of us have shown today, all the angioplasties and everything, we are doing it more in terms of patients who have critical limb threatening ischemia, which means they do have tissue loss and all. But there will be a certain subset of patients and all who may have a small ulcer which is not healing and all. And what you want is to keep a longer patency, because they have to walk on their own feet. Because looking at the evidence which is there, that 50% of these patients are going to die in 5 years if they land up with a major amputation. So I think one thing which is very important, that in younger patients who are physically fit with minimum comorbidities and all, if they can be subjected to a bypass and all, of course, in certain situations, I think it still is probably the treatment of choice in certain situations. I would say if you have to do an above knee bypass or something of the sort, using a saphenous vein in certain situations, of course, is very, very good. And wherever, endovascular, unfortunately, especially below the knee treatment, even in a place like India, not very many people are doing structured BTK work, as we call it. So that is where probably one needs to have surgeons who are trained to do below the knee bypasses, and they do have phenomenal results for that matter. So I have some of our patients and all going back 10 years, 15 years, 20 years down the line, where the bypasses and all are absolutely patent. And whereas you have another subset of patients where the primary endpoint is only wound healing. When you have tissue loss, you have wet gangrene and all, you just want this patient to heal at the earliest so that he doesn't die of any comorbidities and all. So I think that is very important, that you have to choose the right therapy for the right kind of patient. So this is what my take would be. Maybe Eddie and Rahul can weigh in on that one. Well, how do they think about the role of surgery?
I would agree with you in that, we always try, to remind ourselves not to forget about bypass as an option. Having said that, in practical terms, we see most of our diabetic patients, the trouble is with the distribution of their lesions. They are almost always very distal below the knee. They're very small arteries. So a lot of them are not amenable to bypasses, even distal bypasses. So I have to say, in reality, 98% of our cases are treated endovascularly. Of course, you have the occasional ones with long SFA occlusion. I agree with you. A FAM below knee pop bypass, they are much more durable. And also the second thing is a majority of them, even if they have a suitable distal bypass option, they're usually elderly and they're high risk, and so then in the end we still go for endovascular options in the majority of this.
Yeah, Rahul, anything?
No, the same thing. It's just that it is. It's basically for me. I stand to indicate it what I was saying 20 years back. That will always be the first option. Just a joke between both the vascular surgeons. I always make it like that. 20 years back, when I used to present below knee angioplasty or even SFA angioplasty, all the vascular surgeons used to jump on me and say this is all something which is not. But yes, at that time, definitely things are not as durable as what they are now. But I completely agree with both the vascular surgeons that we should never say that surgery is bad or surgery is not to be done. It's all, as rightly said, that in India, diabetics are younger. Please remember that. There are the subset of population in India of diabetic is also a younger population. And even now, we have a very good team of vascular surgeons, even in our city. And if I feel that this is amenable or suitable for surgery, I'm the first one to refer it to the femoropopliteal bypass or something like that. We are the first. Idea is that I think we've all now become pretty experienced enough, and even I think we've all shed our egos that it's not because I can do it, I'm the best, or someone, and it shouldn't, the patient should suffer. It's basically, you look at it as a team. If we feel that all the vascular surgeon says, no, I feel this patient is still a high risk for me to do, then definitely we'll go ahead with the endovascular option. But we try and discuss all the patients as a team, and we then offer the best treatment. What we would feel at that time is for the patient. And that's how I think the idea is to save the foot. So is something where I don't think we can ever say that endovascular is the best or surgery is the best. I think it's a combination of both and what you need to give for the patient. And that's what we are doing. I think India is also matured now to reach that level where a lot of vascular surgeons themselves do endovascular work. So they can also in their own mind offer the best of treatments to them. But even as interventional radiologists who don't do any surgeries, we still will refer a patient for a surgery if required. And not just be gung-ho, frankly, how I was maybe 10 years back and do everything endovascular. But we will look at it that it's a combination of both. So I think it's fantastic with the way the world is progressing. And yes, endovascular is very glitzy. It's like very, very glitzy. It's you finish the procedure sometimes in 1.5 hours. Patients are happy. Patients are awake. Bypass, although may look cumbersome, but actually sometimes the results are even better.
I think what is very important is to treat the patient, not the lesion. I think that's something that our message has to be. And if I can at this stage ask Dr. Nag a couple of points which are there and that is relevant to our specialty today. When would you consider referring a patient to a vascular surgeon? I think this is very, very important for all the general surgeons, who are listening, because many a times, by the time the patient comes to us, he's come with a stinking foot and, somebody promises him the, mana that, okay, this is all going to heal and nothing, you're not going to lose anything and all. So as a person who's dealing with these kind of patients and all, when would be your first choice of sending the patient to a vascular surgeon or any interventional radiologist for optimum therapy?
So I mean, it's quite right, Dr. Bedi. What you say, most of the patients when they come to me, they will be dressing a black gangrenous toe for the last 1 month, hoping it would heal. And the first thing you do, you feel the pulses is not there, and that's a no-brainer, right? I would always, initially, I would refer them to the vascular team, but I mean, no disrespect meant to anyone. The vascular guys, I think, are more interested in doing CABGs right now, so they would probably say, why don't you send it to the interventional guy? So over the few months, my practice has changed. The moment I don't feel a pulse, or I think the ABI is 1.4 or 1.5, I immediately send it to the interventional guy, Dr. Manoj Shah. He works with us in Apollo.
Yeah, I know.
You may have heard of him. So he's sort of a kindred soul. So I send him all the dirty wounds and the ulcers I can, and he does a great job, So instead of ending at a BK, I usually end up doing a midfoot. So they still lose a part of the foot because they already come with a black toe, but I can save a lot of limbs. I'm sure it's the same story everywhere.
So I think a couple of things which bring it to my mind is come to my mind is one, of course, in a place like Delhi, we see the maximum incidence of diabetic feet patients coming to us during the winters.
Yeah.
And you know why? The commonest reason is because of a bad neuropathy. These people in the dense winters, they have these hot air convectors and all out there. They keep their feet nicely in front of them. And then because they have absolutely the insensate feet, suddenly they come with blisters or blackening toes and all that sort of thing. And because they've got no pain, even the people in the household also tend to ignore them. And then once they come out there, they have a foul smelling wound with a lot of blisters and tissue loss. And then you're at your wit's end as how to treat these patients, because most of them will have, some element of vascular compromise also. The second point, which we see again very commonly today, is that even if the patient has got a neuropathic foot where he's got a heel ulcer and all, today I think there is enough evidence. I think Dr. Bedi will also agree and Rahul will also agree that it is not only a lot of discussion that is taking place around the angiosome concept.
Yeah.
But the heel area sometimes is a place where the blood supply through the calcaneal branches and all, the lateral or the medial one, is lacking. As a result of which the wound, in spite of the best efforts by the podiatrist and all, the wound does not heal. And that is again a situation where, in spite of having good pulses in a dorsalis pedis or something of the sort, you may still need to do something. So a comment maybe on that one from Bedi also and Rahul.
In terms of the heel ulcer?
Yeah.
That's a different ball game altogether. It's a completely different beast when you're talking about heel ulcers. Our first approach to that is, number one, it has to be strict offloading. Elevate the legs, off pillows, heel cushions, and the patient has to be prepared for a very prolonged journey. And secondly, in those instances, like you say, toe pressures, APPI doesn't mean a thing. For example, only 2 days ago on a Saturday, I had a patient with a toe pressure of over 100. But this is all blood going through the anterior tibial artery, dorsalis pedis, but the perfusion to the heel is still poor. So for those, I will still offer revascularization, definitely get the posterior tibial artery to the heel as best as I can. And after that, you got to control the infection. You got to go for your local ulcer treatment, meticulous, and they stay in hospital for quite some time. And despite your best efforts, I only tell the patient that at this stage, we can only save 60% of patients who present with heel ulcers.
Yeah, that's the biggest challenge actually. The heel ulcers are the biggest challenge which are there. Yeah. So Rahul, you have any different take on this, or you also agree on that?
No, completely agree with you guys. When we see a heel ulcer, we as a team, because we do have weekly meetings also, and we always see the heel ulcers are the most challenging, and they do land up with below-knee amputations. And the problem is to convince them, because a lot of people say it's only at the heel, so why can't you just do something and save it? But the sad part is once you lose the ankle, obviously you can't do anything. So it takes a lot of time to convince the patients that, even with our best of efforts, as Dr. Bedi rightly said, 60% can be salvaged, but 40% patients land up with a below-knee amputation with a heel ulcer. So the idea in the whole thing is we try and counsel our physicians, the general practitioners, the general surgeons. Don't waste too much time trying to treat it in your clinic for a long time. If you feel it's not having a good effect within maybe, let's say, 5 to 7 days, refer it to a diabetic foot surgeon. It doesn't have to be us or our team. Refer to any diabetic foot surgeon, and then hopefully they can get things done earlier, get the best of treatments in, because it's still a relatively tertiary care treatment which is required. It's not something can be done at a primary level, sadly. You can do the basic levels at a primary level, but mainly it's a tertiary care treatment. So it needs to be done in a big hospital with experts at all levels to get this treated, and not only experts of vascular intervention. You require people like Dr. Nag, you require his whole team, the footwear people, and sometimes very difficult to get it into a small setup. So we are trying and convincing a lot of our patients, but it is improving. So it's not something which is disastrous or something. What we were 10 years back, we are way, way ahead what things are happening now. and patients are coming in early, and we try and make people aware by various social media, by TV channels. It does help. It's maybe a boring subject for a lot, but it's definitely something which we are trying to help and get patients early. So the earlier you see, the faster, the better the results. Obviously, the later they come, sadly, we'll have to counsel them for even below knee amputations at times.
So if I can just bring on Sujoy in this conversation out here, I think we've all been discussing between ourselves and all. How do you look at, I alluded to that in my last part of the presentation about instead of patients coming to us as having an outreach program in terms of managing the diabetic feet and all. I think this is where, because we are doing this under the umbrella of the Indian Chambers of Commerce, how does this, this translate into the industry, having some kind of a partnership and all where we go across, you see like this picture which I showed you of Bangalore, the World Diabetic Foundation, which is, sponsoring a lot of these events and all where you go across with an ambulance, you have a person going across to smaller places in India, because that is a major challenge, and trying to treat patients at a smaller level. So do you think the role of industry is there in this one? Sujoy, if I can bring you in and on the conversation.
Absolutely. I think, it's very important to create that awareness, which most of us who are not from the fraternity, from the medical fraternity, we have. For instance, somebody like me who is not into not a part of the medical fraternity, but we are facilitating the healthcare sector by being a part of, the Indian Chamber of Commerce. For me, this is an eye-opener, because honestly, I did not know so much that it can be so fatal and things can be so bad. But similarly, I'm sure there are hundreds and millions of people who are as clueless as I am and it definitely, like you said, it's like a pandemic, right? So definitely, we need to make these people aware. And surely, as a chamber, we can partner in spreading this awareness. And definitely, we would be happy to gain some of the corporates who might be interested as part of their CSR initiative, possibly, to take these things forward and see what we can do. We can surely discuss this offline and see what we can do. Surely, in fact, that is the intention. That's what I would like to say here, that the webinars or this, so far we've been doing only physical conferences. But COVID has given us this opportunity to get speakers and delegates from across the world together, right? And create a lot more awareness than we could have probably created in the physical events, because there's a lot of logistics involved there, right? Which is not the case here. So I think, for instance, see the panel. We have people from different cities and from Singapore, and we've all been able to share, your views, and the audience has definitely kind of taken note of it, and we can surely, between all of us, best we can do to create awareness, surely.
I think that'll be great, actually.
I think I would also like to take this opportunity to individually thank each one of you for your time, for your effort, and for supporting Irene when she has got to you, and the support that she's received. So on behalf of the Indian Chamber of Commerce, I would like to thank each one of you, Dr. Seth, Dr. Bedi, Dr. Chok, and Dr. Nag. Thank you for your time. Thank you for being a part of this session. And I would also like to take this opportunity to thank our sponsors who have come forward to support this initiative. So thanks a lot. Look forward to hearing from all of you more and involving you more in whatever we do in the days to come.
Thank you very much for the opportunity. It's been wonderful.
Thanks a lot.
Great. All right. Bye-bye. All the best. Take care. Stay safe. Bye.
All right. Thank you.
Bye-bye, everyone.
Yes.
Thank you very much.
Bye. Bye.
Stay safe.
Thank you. Bye-bye.